There was a little rush in your thing, in your half hour. Sorry for that, but the organizers rushed you, because now we are going modern. We go to Germany, and we have an open line with Germany. I hope that there will be signs of living beings in Germany, and if we see one, fascia as internal sensor. Robert Schleip, physical doctor, MA, and he wrote a book, Fascia in Sport and Movement. You can buy that. The price is only $59.95. Good job. Yeah. Dr. Schleip, can you understand me? Can you hear me? Können Sie mich verstehen?
I hear you perfectly well, and I thought it was an excellent introduction. Yes, I'm alive. There is life here in Germany as well.
Please tell us your story, and we be, as we say in Holland, hanging on your lips, and we don't say that often from Germans. Thank you.
Thank you very much, and I also agree with you. This is worth a modern experiment, because as we say in our small group at Ulm University, if you want to understand fascia as a networking organ, it works very well if you train your own networking skills. And that's what we have been doing in the last years. And you linking with me today with the modern media is another way of networking. Because the time of individual geniuses, whether they are Andrew Taylor Still or Ida Rolf, or you name them, who try to create everything out of their own mind, is definitely over. If we want to understand complex relationships, for example, how the fascial net links with our internal sense of self, it works much better if we link to other like-minded individuals. So my talk is called Fascia as an Internal Sensor, and I think it relates very well to the opening speech of the previous speaker, who was looking at the importance of our first-person experience of ourselves through our body. And what I learned in the last few years is that a lot of that self-sensing capacity seems to come less from our joint receptors, less from other receptors in the body, but mostly to a large percentage from our fascial network. And I don't need to tell you that fascia had been neglected for many centuries as a mere packing organ, and that now it's been rapidly discovered that it plays much bigger roles, for example, in force transmission. But in this talk, I want to look at fascia as one of our richest sensory organs altogether. So if you talk about the fascial net, not only about the dense, irregular connective tissues from classical anatomy, but also from the various layers of the intramuscular connective tissue. And if you also include aponeurosis, tendon sheets, septi, and also the superficial fascia under the skin, then it comes close to our so-called richest primary sense organ to seeing. So we have probably around several 100,000 receptors in our body-wide tensional network that is called the fascial net. And you can look in the literature, they are usually divided into 5 different receptors, and most of them are more sensitive for stretch stimulation than for compression stimulation, which I think is quite interesting. So any kind of stretching, yoga simulations would be much more intimately linked with perceiving our body through our fascial net than if we just apply pressure. In this talk, I want to emphasize briefly on 3 aspects: on the sympathetic innervation of our fascial net, on the proprioceptive innervation, and on the, and I think that is the most interesting, the interoceptive capacity of our fascial network. What I'm leaving out is the nociceptive capacity, that fascia can also be an origin of pain, but that is a subject by itself. So let's look at the sympathetic innervation of fascia. That has been very nicely proven by the laboratory at Heidelberg University in the team around Siegfried Menze. So with a certain antibody that only stains sympathetic nerves, they showed the rich presence of sympathetic nerves and nerve endings in our fascial tissues. In fact, the majority of nerves that are terminating into fascia seem to be sympathetic nerve endings. So we have a very high richness of these nerves. And the question is, what are they doing there? Why do we have this intimate link between our autonomic nervous system and our fascial body network? Part of it definitely has to do with regulation of blood supply, and that's why you find a lot, but not all of them, of these sympathetic nerves in the vicinity of blood vessels. And that would explain their known function. However, there are several of them, many of them, who are not in the vicinity of blood vessels, for example, shown in the lower left picture. And there we need to understand what are they doing. And at this point, nobody really understands what is the function of the sympathetic nerve endings in fascia that are not terminating next to blood vessels. It is suspected that they may have a trophic function, that they are sensing and regulating the expression of certain hormones and cytokines in the vicinity there. What is quite interesting is some new studies done at Mannheim University, where they exposed laboratory rats to what they consider to be a mild psychological stress, in which you put them in a cage for 1 hour per day on 12 consecutive days. So you're not torturing them, you're not putting any painful manipulation, physically painful. Basically, it is a forced immobility. If you're a couch potato, you're doing that voluntary. So you're sitting on your chair without any large movements. But here it is done without voluntary consent, and that causes a significant stress on these animals. And very interesting enough, it changes the activity of the dorsal horn neurons, that they tend to have a long-term increased activity that results in a reduced pressure pain threshold in deep muscular tissues. So not the pain perception is changed in relationship to pinching or tweaking or pain stimulation or anything, but it is the deep pressure that we may be applying, for example, in manual therapy. And there is an interesting relationship that if you have chronic stress, that deep pressure pain threshold seems to be increased in opposition to other kinds of pain sensitivity. And that may be a nice explanation for a very new study that came out, also in the group around Siegfried Menze, where they compared low back pain patients and their sensitivity to various kinds of stimulation in normal low back pain patients and those low back pain patients who had an issue of childhood abuse. So their nervous system is suspected to be in a long-term chronic sympathetic activation. And very interesting enough, it is mostly the deep pressure threshold, not only in the low back, but also in other areas of the body, that is diminished. So if you pinch the skin, nothing is different in those traumatized patients as opposed to normal low back pain patients. If you put needles of various sizes into their body, nothing is altered there, but the deep pressure pain threshold, that is altered in these patients. And that seems to be related to the sympathetic activity and possibly to the activity in these fascial receptors in these deep tissues. So let me then shift from the sympathetic capacity to proprioception. That means feeling my body in space and in movement there. Did I lose the picture here? I hope not. So here we go. A very interesting finding is that the density of proprioceptive nerve endings in fascia is not the same in various areas of the body. Carlos-Deco and her team at Padua University have shown that certain fascial membranes that transmit a lot of mechanical tension, for example, the lacertus fibrosus shown on the left, that is a part of the biceps of the forearm, and it has been shown that this one, if you cut it away, it dramatically alters the force transmission. So it has a much bigger mechanical function than was assumed in classical anatomy textbook. However, when you look at the proprioceptive function or the proprioceptive density, it is very little. And if you compare that with the retinaculum of the wrist shown on the right side, but also the retinaculum of the ankle, it has a lower mechanical significance than I had assumed. So it means you can cut it away and the tendons still transmit their tendons, the mechanical tension, pretty much the same as they did before. So they are not needed for stabilization of the tendons because they are already glued together by their epimysial envelopes. So low mechanical tension comparatively, but a high proprioceptive innervation density. And that is now very interesting. So if you want to do fascial or osteopathic manipulation and increase the sense of their body in space and in movement from the inside, not through their eyes, but from the inside, then working in these areas where you have retinacular tissues could be possibly or most likely more rewarding than when you randomly work on tendons that have a high force transmitting function. Another interesting surprise, and I didn't like that when it came up as a Rolfer, because as a Rolfing practitioner, we believe that going deeper is meaning having a more profound effect. Whereas the new research, also coming from both the German group and the Italian group, has shown that the proprioceptive innervation density in superficial layers of fascia is much denser, much higher than in deeper layers of fascia. And that is very interesting. So the layer between the skin and the sliding layers of the skin and the superficial fascia and the dense layer of fascia profunda underneath, there is a sliding or a shearing zone. And in some areas you can slide it freely. On others, for example, if you had an injury, the sliding is inhibited. In this sliding zone or shearing zone, how we call it, you have the highest density for proprioceptive nerve endings. And that would mean that if you pay attention to the skin level, maybe you reinvent cupping again, or you roll the skin, it may possibly have, at least for proprioceptive innervation, a more profound effect than if your Rolfing practitioner plows all the way in to work on your psoas muscle because it considers it to be more deep and therefore to be more profound. So these are just two of the stimulations that came up in the last few years in regarding to the proprioceptive capacity of fascia. The most interesting subject of this very short talk of mine is a third capacity, which is called interoception. And that is feeling your body, not so much in biomechanical terms, but in relationship to your physiological needs. So whether you feel coldness or warmth or tingling, whether you feel sore muscles, whether you feel your heartbeat or not, whether you have whether you feel your intestines in terms of a full bladder, empty bladder, whether you think you have eaten too much or the wrong food, but also if you feel tickling or itching under the skin, if you have a subjective sense that you don't get enough air. All these are body sensations which come from free nerve endings that are not related to the somatomotor cortex primarily, but they project to a part of the gray matter of the forebrain, which is shown on the upper left picture, which is called the insula of the frontal lobe here. And this is where we sense our body and compare it with our physiological needs. And the receptors, many of them are in our intestines. Many of you, you know, it's now called the second brain, our enteric brain. It has several hundred thousands of nerve endings, and the small connection to the brain mostly goes to the insula shown up there. And this is very interesting. The main pathway through which we have a sense of self and identity in philosophy. The main researcher on that field is Dr. Craig, and he has done a lot of studies, for example, in several schizophrenic disorders where the sense of self is distorted. You will not support that very well by doing proprioceptive stimulation, but by getting a better communication between the insula and the peripheral stimulations in your bladder, in your muscles, etc. What is different from proprioception to interoception, among many other things, is it's always colored by an emotional association. Either it moves you towards well-being or it moves you away from it. So you always have an emotional coloring in there. And our sense of self, that when I wake up in the morning and I'm clear, I'm no longer dreaming, this is me, and I'm one, I'm not many pieces fighting with each other. This sense of self, I do exist, and I'm a living being. I'm not a ghost talking from a slide beamer, slide projection here. This sense, I am alive, it comes very much from these many tingling visual sensations of our body. And what was a big surprise for me is the red arrows shown here on the right, that we humans have a highway, a direct shortcut from the peripheral stimulations of these nerve endings towards higher centers of the insula. So it would mean that we are anatomically wired to have a stronger interoceptive sensation, a stronger visual sense of ourselves than our dog or our cat or even chimpanzees have. And I often, if I look at the way how fragmented I now live as a researcher, I used to be much better connected when I was mostly a rolfer and movement therapist. So if I look at how disconnected I sometimes are, I think my cat or my dog have a better sense of their connection. Maybe that's true, but anatomically, we are the mammal that has the strongest direct link of our conscious perception of ourselves and these interoceptive sensations. Now, very interesting, there are several disorders, and that is now the subject of your conference, Orlos, otherwise unexplainable disorders. On the left side, you see disorders where research has shown that they go along with a disturbed proprioception. For example, in low back pain, the 2-point discrimination threshold is largely increased. So it means your mechanical proprioceptive sensation is diminished. Same thing in phantom pain. Also in attention deficit hyperactivity syndrome, proprioceptive stimulation would make a lot of sense. And in complex regional pain syndrome, in scoliosis, one of my favorite, in whiplash, and probably also in other myofascial pain syndromes, as opposed to visual pain or to headache, etc. However, there are many clients coming to our table, to our treatment, who have also, or instead, they have pathologies on the right column here. For example, most of the eating disorders, they don't go along primarily with proprioceptive dysfunctions, but with interoceptive dysfunctions. Also, depression and anxiety, a layperson may think they are very different, but research has shown they are very common in terms of the neurological activation and inhibition patterns. Both of them go together with a diminished, disturbed interoception. Alexithymia is emotional blindness. So it means that you are not aware of your emotional state. Everybody else knows that Robert is very grumpy today, but he denies it. And of course, that can destroy marriages, and it also can influence your lack of empathy. If you cannot feel your own emotional state, how can you feel the one that you are talking with in terms of your patients? So that causes a lot of suffering. You know that better than I do from your patients. The lack of empathy that they have, and also the lack of understanding their own energy states, you could call it. So it's not a physical pain, but mostly emotional pain. That lack of sensation of your own and others' emotional state is related to interoception, and it goes together with also not feeling your bowels very well, not feeling your heartbeat, not feeling your temperature sensations, etc. Schizophrenic disorders, yes, they go along with a diminished interoception, and post-traumatic stress disorders. Here we come back to them. So many patients, their acute pain is linked or augmented by the emotional chronic stress that they had in the past and that may still continue in the future. If I then know that interoception is the primary sensory function in their fascial system and not proprioception, I can use my treatment different. Fibromyalgia is written with a question mark here because new research has shown that their sense of temperature regulation is largely changed and that there are even nerve receptors specialized on temperature regulation and temperature sensation, which are dramatically increased in their numbers in these patients. So maybe that is the primary disorders, and the pressure and movement pain they have may be secondary to that. So coming to a closure here, it would mean as a body or movement educator or therapist, if you do have somebody with whiplash disorder or with low back pain, you should emphasize therapeutic strategies written here on the left. For example, classical Pilates work is perfect for somebody who needs to feel their body in terms of geometric and biomechanical relationships. Also, I'm a Feldenkrais practitioner myself. Classical Feldenkrais work emphasizes on training your sense of positioning on the table, on the floor, etc. Rolfing movement, classical Iyengar yoga, the FM Alexander technique, segmental stabilization techniques. You don't pay attention to any tingling and bowel sounds. No, that is secondary. But which shoulder is more forward? Which leg is moving more, etc. Now, these may be very beneficial if you treat somebody with low back pain. However, if you have somebody with post-traumatic stress disorder, if you have somebody with schizophrenic disorders, if you have somebody with alexithymia, with this emotional blindness, you may emphasize and train more the therapeutic strategies written here on the right. For example, the Kneipian or hydrotherapies, in which you do sauna treatments and feel the tingling afterwards, after you get into the cold water or the warm water, and you regulate and you train your temperature sensation. If you put warm packs on your patients, just like a cheap paid German physiotherapy does for 15 euros an hour, they may be possibly more effective than you €100 per hour charging osteopathic rolfing, whatever you call it, mechanical practitioner in the right patient. Visual osteopathy may be also a sensory stimulation of these free nerve endings that stimulate your insula in your brain and give you a sense, I do exist. I don't need a philosophical argument around it. I feel it from my guts. I am a living being. So if your client leaves the session by feeling more together, it may be because of your visual stimulation, not only doing mechanical changes, but also visual stimulation that then link to the insula in your brain. Now, in the somatic community, I'm a great devotee of Emily Conrad with the continuum movement, body-mind centering. These are all these bodywork practitioners, practices in which you ask for a mindful perception of the felt body from the inside. And the smaller the sensations, the more valuable they are. Now I put energy work with a parenthesis here because as German scientists, we tend to make cheap jokes about it. So if somebody puts crystals on the client to get their meridians streaming more chakra energy through it, you can already hear it through us. I consider it as being less efficient and less profound work than if I come with my profound anatomy knowledge and I'm very clear on which layer of fascia I supposedly am working. However, if the client's attention is directed to what they consider energy streaming, it may be in some of your patients, those from the right column in the previous slide, post-traumatic stress disorder, eating disorders, etc., more profound than somebody doing biomechanical work. So lunar yoga, in which the client thinks about certain chakras in their body and energy streaming in it, may be more profound than somebody doing very precise Iyengar yoga, etc. And very interesting, that is a lecture by itself that I will not go into this brief lecture, the sense of affective touch. There is a new type of tactile C fibers in the skin and the superficial fascia. So if you do a stroking on the skin at about this speed, the insula feels I'm connected socially. And you have a better digestion, you sleep better, your cortisol level goes down. And even if you don't know where the touch happens, you feel better connected there. And that may be that if you touch somebody, not in order for any biomechanical changes, but you touch them with an effective quality. This is not fixing your back pain, but it just touches you in a way as you stroke your cat, that there are tactile C fibers under the skin, tell them I'm not alone on this world. I'm sensually connected with peer human beings on this planet. That would be another interoceptive stimulation for these patients. So let me summarize this talk, and possibly we even have time for questions then. The fascial network, if you look at it in a wider way, and you include all the intramuscular and also the superficial connective tissues, is one of our richest sensory organs altogether. And it provides a very intimate link between our autonomic nervous system and our body. And there is a lot of things that we need to improve in our understanding there. It is also probably our most important origin for proprioception. So whether I know without looking, whether I have a low doses in sitting now in front of you, or whether I don't, actually in sitting here, I'm just realizing that the sun has been shining through the window into my face, and I did not perceive that. If I had a better interoceptive sensation, I would have not focused so much on my slides. So this is a nice example for the interoceptive sensation, and all of them together constitute our sense of self. So let me thank you, and let me thank all the people who have traveled this adventure tour of understanding the fascial network in my own laboratory, shown here, but in the international network, including people like Leon Chaytov, Thorsten Liem, and many of the fellow researchers that are present in your room at your enviable conference. Thank you very much.
Thank you so much, Dr. Robert Schleip. And as you could hear, applause is international. Any language is applause, applause is any language. One question from my side. Where is osteopathy in your world? Where does it have a place?
I think more on the interoceptive side, as opposed, for example, to a normal physio and even to an old-fashioned trained rolfer like me. Because you place a lot of attention in most osteopathic schools, not in all of them, on the mindful listening quality of the practitioner, and that also through the empathic relationship colors on the patient. And if you include visual stimulation, if you include that listening touch, and also, but I don't think many schools have been emphasizing that systematically, if you foster the listening mindfulness of the patient to their fascial network, you would have the most profound stimulation of interoception that I currently know. However, if the client is talking with their wife on the mobile phone while you do an osteopathic manipulation, I've never seen that, I think you can work as great as you can, but you will not reach the insula as well. So the mindful attention of the practitioner is a dimension that we actually are planning to do more research. So if you distract the attention of the patient, you would have possibly lower effects, even if you have full attention of the practitioner, as opposed to when both of them have their full mindful attention in the area of interaction as well as in other body areas.
Last question, is osteopathy popular in Germany?
It is very popular. Talk with Thorsten Liem, and much of the popularity is thanks to not only his own genius, but also to his networking skill. How well he emphasizes information of inspiration and information with other also competing osteopathic and other bodywork skills. This is something where we all can learn something. Yes, it's very popular here.
Okay, it's lunchtime for you, it's lunchtime for us. Wir bedanken uns sehr, Herr Doktor, und tschüss.
Ja, noch eine schöne Konferenz. Vielen Dank. Ein toller Titel.
When you hear him talking, it reminds me of a television series, and you all know that. There was a German who spoke English very funny. Von Gelb, das war sein Name. Yeah, you remember that? And it's a kind of English we poke fun of. But you sit there at the desk and you talk for half an hour, and you don't even see one human being in front of you. It's a nice thing to do. Is it time for lunch? Time for